Let's talk some fungal and viral infections. So you definitely got to know the basics that, fungal and viral infections are treated differently from bacterial infections. That's step one. I'm going to definitely talk about specific infections here. Fungal infections are much less common, I would say, as far as severity. Oftentimes they will present on the skin in different forms that way. Systemic fungal infections are very, very rare that they happen, and the setting where it's most likely to happen is in the setting of immunocompromised patients. Viral infections, going to touch briefly on influenza, HIV, shingles as well, just to give you a good background in some of the drugs that might be used there. So first with fungal infections, we've got athlete's foot, Tinea pedis. Remember, like podiatry, pedis, that all kind of surrounds the foot and the toes. And it's basically this kind of cracking, redness, itching of the skin in between toes and on feet. Oftentimes you'll hear it spreading amongst community showers and things of that nature, where you've got that warm, moist environment where fungi grow the best. Treatment, management, usually topical. Antifungals are the drug of choice. We really don't have any side effects or any concerns that way typically. So that's the route to go initially. Keep in mind, and this is a really important patient education point, you can't just do Lotrimin or Nizoral or Lamisil or whichever one you're going to use. You can't just do that for 2 days, 4 days, 6 days and expect that infection, that athlete's foot, to disappear. Fungal infections are slow growing, and they're also slow to kill and get rid of. Orals, we avoid them, especially for, mild cases and non-complex patients where, they've got a healthy immune system and all that sort of stuff. So avoid orals in that case. If something is necessary, if it gets out of hand, or maybe the topicals weren't effective for whatever reason, and or maybe we're concerned for some odd reason about some systemic involvement or something, then we might see the orals utilized, and fluconazole or diflucan is probably the most common one there. And a lot of these antifungals work pretty similarly, like fluconazole and amphotericin B, which I'll talk about coming up ahead here. They work on fungal demethylase, which prevents formation of ergosterol, which is important in fungus development, growth, and part of their membrane and exterior. So by inhibiting that, obviously you prevent the fungi from growing and reproducing themselves that way. Diflucan, yeah, absolutely. With the azoles, you have to remember CYP3A4 drug interactions. I'll talk a little bit more about that coming up. Tinea cruris, this is jock itch. Again, very similar type setting as the feet, warm, moist environment. And anything we can do to kind of keep these areas open air and exposed to air, keep them cool, keep them dry, definitely can be helpful in preventing the growth, preventing the spread. Again, topical agents, you got the azoles in there, terbinafine, which also, has some potential to kind of work on that fungal membrane. Ringworm, terbinafine, Penlac, you might see those agents utilized. If it's severe enough, you may see systemic azoles like fluconazole used. Terbinafine does come oral as well, so that's Lamisil. Now this will probably be the most important antifungal medication class that you're going to have to be aware of. So, you've got ketoconazole, fluconazole, clotrimazole. all these different medications that are available, topically and orally. As far as the side effects go, I'm talking more so on the oral or systemic absorption side of things. So GI, liver, that's something that may be a little concerning and something to keep an eye on. Not real common, but maybe keep an eye on those patients at higher risk for trouble there. Or maybe on, medications that impact the liver already, statins, nifazodone, and so on and so forth. Again, nifazodone being a pretty rare medication, but if we've got multiple meds that impact the liver, that could potentially be a problem. A lot of the RA drugs, another example there, that may affect the liver. CYP3A4 inhibition. So fluconazole, definitely a lot of drugs, their concentrations can be raised by using fluconazole, and generally not in a good way. So I've definitely seen issues with warfarin. I've definitely, in raised INRs, I've definitely seen issues with seizure medications. I remember a classic case where fluconazole was added, a 14-day course once a day, and a patient ended up with dilantin or phenytoin toxicity because of this interaction. So have to keep that in mind. Look out for adverse effects from drugs that may be increased by the addition of the azole antifungal agent. There is QTC prolongation risk. I always think of patients on amiodarone maybe being at highest risk, but if you've got an EKG, if you've got access to that, that might be helpful to make sure they're not too high already, or they haven't had issues with that in the past if we're going to use an azole antifungal. Thrush, so this is that infection in the throat and mouth region caused by Candida albicans, and it can be really, really troublesome for patients. It can lead to really severe throat pain, difficulty swallowing, maybe even shortness of breath and breathing issues if it gets so overgrown. And patients who are immunosuppressed, like most of these fungal infections, are certainly at higher risk. So patients recently on chemo, HIV/AIDS patients, patients taking steroids recently, and one of the biggest education points that I find myself making to patients is rinsing your mouth after the use of Advair, Symbicort, budesonide, all these inhaled corticosteroids. Definitely got to remind patients to do that, and that's to help prevent this thrush type infection. Treatment, we've got a few different options there that we can utilize. Ampho B, we're likely not going to use that for a walking, talking, somewhat healthy patient with thrush. That's more of a absolute life-threatening, probably immunosuppressed, immunocompromised patient already in the hospital. Yeast infections caused also by Candida albicans. Itching, burning, cottage cheese type discharge from the vaginal region there. It may be one of the most common things I see is patients a little more at risk with the immunosuppression, which we talked about with all the other fungal infections, but also who've had recent antibiotics, because we have normal flora bacteria. And if we use, broader spectrum antibiotics or frequent antibiotics, that flora could be upset. And if that's upset or changed or altered, that gives the potential for yeast to grow up, fungal infection to grow up and expand and multiply, causing a yeast type infection. Systemic agents that you might see used here are fluconazole. I have seen it given where, a provider will give a patient, 3 tablets or something kind of to cover them all year because they've had yeast infections. They know what they're about. They know how to self-diagnose. So I have seen that. But you got to remember, if you empower a patient with something like fluconazole or diflucan, you have to make sure that they're aware of the potential interactions and some of the things that can result from use of that medication via 3A4. Aspergillus. This can be a very significant infection, pneumonia type symptoms, CNS type symptoms potential as well. Again, this is more of an acute care hospital type situation, and obviously the patient is probably going to be immunosuppressed in some way, shape, or form. There's probably rare cases out there of otherwise normal, healthy individuals, but I would say most commonly you're going to see immunosuppressed patients that have an infection like this. Now, I did want to cover Amphotericin B. This is always a classic medication with lots of pearls that you could certainly be tested on. There is 2 formulations, conventional and lipid-based, as far as giving this medication via infusion. And they are not interchangeable. Very, very important to remember that. With the infusion of Amphotericin B, it's often called Amphoterrible B because it causes so much suffering as far as the flu-like adverse effects that it can make patients feel really, really bad. So pre-treatment is sometimes done, often done. Diphenhydramine with acetaminophen or NSAIDs. Obviously, you got to make sure that they're a candidate for those medications and not intolerant of those. Sometimes corticosteroids have been used in preventing that reaction, maybe in patients who've had it before where we know they have a really, really severe reaction. Can cause some alterations, some dropping of potassium and magnesium. Amphotericin B is very nephrotoxic, so we have got to monitor kidney function for sure. And there is a boxed warning on Amphotericin B because of all these potential side effects, infusion reaction, electrolyte changes, renal insufficiency. This medication should really only be reserved for a life-threatening type situation. Blastomycosis, so this is a type of lung infection, very slow growing, again, like most fungi. Treatment, itraconazole or azole, one of the azole drugs, and Ampho B for severe. Histoplasmosis, this is a type of lung infection, immunocompromised again, and Itra and Ampho B are potential options. Cryptococcus, again, HIV/AIDS, this is definitely a common infection in those type of patients that are severely immunosuppressed, one of those classic opportunistic infections. Azole, antifungals might be used here, and Ampho B plus flucytosine. PCP, definitely remember Bactrim being the drug of choice there for treatment and prophylaxis. So important to remember that and all the pearls that goes along with using Bactrim in PCP pneumonia. And since we've kind of been on that topic, I wanted to kind of flow into HIV and AIDS, and specifically talking about antiretroviral therapy, NRTIs, and integrase inhibitors, protease inhibitors, and so on and so forth. So what I would really focus on first and foremost is understanding the medications, knowing which medication goes with which class. And then I would memorize class adverse effects. That would be number 2 if I had to prioritize. Number 3 would be knowing kind of which regimens are used together. I think that's an important thing. And then some of those opportunistic infections, I think, is an important thing to remember as well in the treatment and management there. So again, definitely focus on which meds are in which class, and side effect profiles is where I would start. And then if you've got more time and want to have a better depth of knowledge, I would hone in and maybe look at some of the treatment regimens. I'm not very good at knowing the doses on some of these medications. It's not something I would encourage you to memorize unless you're going to be HIV/AIDS infectious disease type specialist, but definitely you need to understand some of the complications that can result from these medications. So some general pearls with HIV/AIDS, there's no cure, obviously. And some of the challenges with the medications is HIV adapts very quickly. The virus changes. There's frequent mutations. So drug resistance is a big, big problem. So educating patients that adherence to these medications is ultra critical. Okay? And that is a challenge because the meds don't necessarily make them feel better at the time. So that can be a big barrier, but they will certainly prevent progression, adaptation, and mutations if they're able to stay on top of those medications and adhere to them appropriately. The immune suppression that comes with HIV/AIDS as the disease progresses, as they target those CD4 counts, the virus targets CD4 cells. Rare opportunistic infections, I kind of mentioned those before. So examples, PCP pneumonia. So I mentioned Bactrim before, Kaposi's sarcoma, type of cancer that would require chemo and or radiation. MAC is a bacterial infection that's rare, but can present its ugly head as an opportunistic type infection. So remember those agents, macrolide, ethambutol, and rifampin. CD4 count. So this is kind of what we follow, what we monitor to help us ensure that the immune system is functioning and functioning at a somewhat decent level. So periodically over time in a patient diagnosed with HIV/AIDS, we're going to be monitoring this CD4 count. And as that CD4 count falls, we're getting to a situation where we're at more and more risk of opportunistic infections. So with a CD4 count, if, for example, here less than 200, we might look at PCP prophylaxis. If less than 50, MAC prophylaxis. Okay, so as that CD4 count drops, it increases our risk of those infections. As far as drugs of choice, we're going to use combinations, integrase inhibitors, NNRTIs, and things like that. We're going to use some of these combos, and that's to really help stay after that virus and stay on top of it, and basically try to help inhibit its growth via multiple different pathways. So the meds. So NNRTI class of medications here. Gotta remember this list of meds, and you have to remember adverse effects. So fat redistribution, buffalo hump, that's a good thing to remember here. Fatty liver kind of goes along with that, so you can maybe remember those two easily. Lactic acidosis, there is definitely potential risk for that. So if you remember fat, so we've got fat redistribution, fatty liver, and fat maybe in the form of increase in cholesterol, as well as lactic acidosis. And then obviously memorizing these medications, that's definitely where I would steer you to start your studies. Integrase inhibitors. So these are somewhat newer than some of the other agents, and they've definitely got a better adverse effect profile than something like the protease inhibitors and other medications for HIV. So these have kind of gotten into the first-line therapy. And if you look back at kind of that list of often combinations that are used together, you'll see that an integrase inhibitor is in those combos. Adverse effects, GI, keep an eye on liver and CPK issues. So if you've got a patient on a statin, for example, that might be a situation where we have to be a little diligent and making sure that we are monitoring that LFT and CPK, because the statin could impact those too, potentially. Immune reaction, Probably pretty rare. Skin reactions, those can kind of happen with any medication. Protease inhibitors, you got to remember 3A4 interactions with this type of medication. Buffalo hump, that kind of fat redistribution can happen with these as well. I mentioned that before on a previous slide. Elevated blood sugar, so in patients with diabetes, that can certainly be a little problematic. Rash, again, kind of goes with a lot of these medications. And mechanistically, through pharmacokinetics, we actually have in the past utilized ritonavir to help boost concentrations of lopinavir. So again, using kind of that 3A4 inhibition to our advantage. But if you get a patient on 10, 15, 20 medications and you try to put them on a protease inhibitor, there's likely going to be some drug interactions that you have to deal with. So that's really a big downside to the protease inhibitors. NNRTIs, efavirenz is kind of the one I always remember learning there. Definitely remember rash. CNS changes can happen, but rash is probably a little bit more prevalent with this group of agents compared to some of the others. And yeah, rarely you may get psych, mood, behavioral type changes as well. So in somebody that's maybe pretty sensitive with that, or maybe they have a history of schizophrenia, severe depression, issues like that, we'll definitely want to maybe keep a little bit closer eye on that, make sure we don't exacerbate that type of patient. And then liver, we need to keep tabs on that and monitor that as well. Influenza, so highly contagious. We talk about it every year. Vaccination at this time is annual, and that's pretty much for everybody 6 months and older. I do talk more specifically about vaccinations. We do prophylaxis with Tamiflu in an outbreak type situation where maybe one family member has influenza, and they're obviously going to be around each other quite a bit. Another situation might be within living facilities like long-term care or assisted living, where people are living in close quarters to one another, and maybe there's a couple with influenza. And so we might consider prophylaxis in patients surrounding that area. Elderly and young, at least in the strains we've historically had the last several years, they are at highest risk for complications. The young have decreased lung capacity, and certainly influenza impacting those lungs and breathing, as well as potentially contributing to a secondary pneumonia, can be a big deal. Elderly, again, kind of reduced expiratory flow, reduced breathing difficulty, maybe they have COPD or other respiratory illness. Those patients are at huge risk. And actually the higher dose vaccination is generally preferred in that patient population. Now the meds, neuraminidase inhibitor, the one we use is oseltamivir. I honestly haven't seen any other medications used. It's a drug of choice for treatment and prevention. With treatment, I think for most any viral infection, the sooner the better. If we know that they're positive, get it started as soon as we can, and that can help improve the course and the outcome of a patient with influenza. It is a little bit costly. That can sometimes deter patients from wanting to do prophylaxis and things like that. Keep an eye out for kidney function. It does require you to back off the dose. Rarely side effects. Have seen some psych issues. Probably more commonly is GI upset and things like that. So definitely keep tabs on that. And this is one where the dose is different, definitely for prophylaxis versus treatment. So higher dose, obviously, for treatment. Shingles, another viral type infection caused by really reactivation of the chickenpox virus or varicella zoster. Really painful neuropathic type pain that patients can go through. It can involve the eye. I just touched on that briefly within the eye disorders section. Treatment for shingles is prevention. That's really the best. We do have Shingrix, which has shown improved efficacy over Zostavax. It is 2 doses and potentially a little more costly, but it definitely has shown more effective reduction in reducing risk of shingles. As far as timing of that vaccination, in that 50 to 60 age range is usually the target there. If patients have an outbreak, and we obviously, vaccination is useless at that point. They've already got an outbreak. Get that antiviral therapy started ASAP. So acyclovir or Valtrex are usually the drugs of choice there. And again, sooner the better. In shingles, acyclovir, one of the challenges is it's dosed multiple times a day. And side effects-wise, GI, rarely, probably more possible in patients with poor kidney function. You may see some CNS issues, confusion, sedation, things like that. Again, pretty unlikely, but in a patient that does have some trouble with their kidneys, could be a little more possible. For shingles pain management, we're going to kind of classically use our typical neuropathic pain medications.